Well, I guess we could start. People that don't know me, I'm Stu Gillum. I'm the moderator of this group. Format for this afternoon's is I will first be talking about treatment of motor symptoms of Parkinson's disease, both medical and surgical. And then I will then go on into the Care Partners group has come up with a list of questions that they have about Parkinson's disease. I found them rather interesting and learned all sorts of new things. So the second part of my talk will be answering, saying what the questions were and the answers to all those questions. And if anyone runs out, if I run out of questions, everyone else is perfectly free to be asking what's been bothering them about their knowledge about the disease. After my talk, we have time for cookies and conversation, and then the Care Partners will head upstairs to the third floor. People with Parkinson's will stay here and commiserate and share stories and information to help us navigate this disease a little bit more intelligently and carefully. Trish.
Okay. Anybody new here? Anybody new? Make sure you get a name badge. There's green cards in the back to fill out so we can get you on the email list. I'm Trish Haggett. I'm facilitator for the caregivers. So after our meeting, after our chocolate chip cookies this time, no nuts in them, just less chocolate chips. We'll go up to the third floor by elevator, go up the long hallway. There's a great big conference room at the left after the long hallway. So we'll meet up there for about 45 minutes and go over everything. As I mentioned, every month we do have 2 scholarship programs that the steering committee has put together. The one is, and the forms are up here. You can also download them from the website, which is Parkinson's Support Group of BellfingerLegs.com. So you can put that in. So the John Paul Memorial Respite Scholarship Program is in memory of our founder of our support group, and these are $100 scholarships. Fill out the form. This is for respite. This is to give you a break. So you can use it, go to dinner, get some wine, go have a massage. You know, it's kind of unlimited. So the forms are there. Steering committee meets once a month. We review the forms. So you can download it or you can fill it in, mail it in. The address is down at the top. The other one is what we call our general scholarship form. Again, the forms are here. And this is for any medical equipment or books, DVDs. Anybody buy DVDs anymore? If you can find them. Anyway, there's a whole bunch of things that we've listed here, but it's not limited to that. So pick up one of those forms or download it. We have an issue from the caregivers. We have the Zoom meeting the 3rd Wednesday of the month at 2 o'clock on Zoom. Caregivers get together with me, and we really get down and deep. So Gail sends out an email with the connection for people with Parkinson's, which is the 2nd Wednesday at 1, caregivers 3rd Wednesday at 2. So all you have to do is click on that link, and it opens up the Zoom opens up about 5 minutes before. So wait for that. Also, if you don't have your email, can't find your email, go to the website. It's right there. Click on it right there. What else?
And for people with Parkinson's, the 2nd Wednesday of every month at 1 o'clock, we have a Zoom as well.
I'd just like to make it, I don't know if you've made this announcement yet. I'm with Methodist Church just down the street here, and today there were no places in the lot. And I had talked to them and they said, if people can't get a place here, you can park behind the Methodist Church. And that's fine, unless it's a funeral and it's full or something. There's an entrance just the south side of the church towards downtown, or there's an entrance off Willie's Place. If you go down Gibson Street, you can come onto Willie's Place and it takes you right into the parking lot. And that's an issue if you're coming from the south, there's a median, you can't get by it. So you can either get at it from here, just down there, or just go around Willie's place and come in the back. So you're welcome to do that.
Thank you, Meredith.
So the first question I have for people is for those with Parkinson's, how many of you have seen a dermatologist that's a skin specialist in the past year? Raise your hands. That's very good. And the reason I ask that question is melanoma, which is a dreadful malignancy, your risk is increased somewhere between 3 and 7 times by having Parkinson's disease. And it's unrelated to the treatment, it seems to be related to the disease itself. Melanoma is a nasty stuff. I spent part of my training at Sloan Kettering Cancer Center. Had one patient who had this horrible cough and metastases to his chest, and his sputum was black from the melanoma. So I encourage everyone to get seen by a dermatologist at least twice, at least every other year, but certainly every year is not a bad idea. Well, everyone has a handout, I assume, and I'll basically be going pretty much according to the handout. What we're talking about is the motor symptoms of Parkinson's disease, not all the other things, not cognition, not hearing, not how your bowels are moving or how your urinary tract is doing, not how your nerves and the arms and legs are doing. It really has to do with how your muscles, and of course we have muscles all the way from the ones in the middle ear to the ones that move the eye and cause your iris to open and close. So that if any one of these muscles is under the influence of dopamine, which is the neurotransmitter, that's the chemical that goes from one nerve to another, so they talk to one another and send signals along. And dopamine deficiency is the primary cause of Parkinson's. Later in the disease, as more and more nerves die off, all the other neurotransmitters start failing as well. There's not enough of them. And that's why many of the non-motor symptoms of this disease appear. It's because of the effect on all the other neurotransmitters. Basically, dopamine is the happy chemical. It's when the brain sends that out to things, everything that it gets smiles. So the absence of dopamine, of course, is a major cause of depression in this disease. And all our therapy that we have, basically all the medical management of this disease or drug management of this disease relates to dopamine. Either trying to increase the amounts or use something that acts like dopamine in the body. If you need more chairs, there's some in that closet. And there are empty seats right in front. I know it's against the law for anyone to sit in the front row. And this is the way it was when I was in school. So basically, there are 2 types of Parkinson's. Actually, there are a zillion types of Parkinson's disease. It presents itself in a number of ways. But there are 2 major categories, and one is the gait balance variety. And that is the one where you have a shuffling gait, you have difficulty with your balance, increased risk of falling. It moves more, it progresses more rapidly than the tremor predominant variety, and is also associated with higher risk of dementia. Overall, someone with Parkinson's disease has about a 20 to 40% chance of developing dementia at some point in life. People with the tremor predominant variety are down in the 20% range. People with the gait balance variety are up in the 30 to 40% range. So, and these 2 varieties behave differently in how they respond to medication. The tremor variety, which is the one that usually starts with a pill rolling tremor in one hand, and it usually presents asymmetrically. It usually presents in one extremity rather than the other, in a leg, in an arm, in the face. That responds very nicely to things that increase the dopamine levels. The gait balance variety does not respond very well to dopamine medication, and people who then progress to needing deep brain stimulation. That also works better in people who have the tremor predominant variety. That's not to say that with a tremor predominant, you're not going to have risk of falling. You certainly are, as the disease progresses. But how the disease begins seems to be a pretty good marker of how well you will respond to medications and what your prognosis is. However, I go back to our founding father, who had the gait balance variety, responded very well to dopamine, responded very well to deep brain stimulation, and lived for 20 years with his disease. So, just because you're in a certain category doesn't mean it's gloom and doom. It just means it's giving a prediction of how well you might respond to our different therapies. Obviously, there are other ways to treat Parkinson's disease other than medicines and other than surgery. And the most important is activities, physical therapy. Physical therapy has been shown to benefit every variety of Parkinson's, and the more you can do, the merrier. It slows the progression of the disease, and none of our medicines slow the progression of Parkinson's. So physical therapy, speech therapy, to help you both with the soft voice that people have with Parkinson's, and also to prevent or to reduce your risk of aspiration, getting food and liquids down into your lungs, are very important. And if you look at all the therapies that have worked very well, it's all the way from dance therapy, which has been shown to benefit people with Parkinson's, to rock climbing, people climbing up walls, which has also been shown to help people with Parkinson's, rowing, boxing, you name it. If you're moving, it's beneficial to your health and will slow the progression of the disease. My quote there is, "The quality of life deteriorates rapidly if treatment, including activity, is not instituted at or shortly after diagnosis." Very good controlled trial that looked at people back not very long ago, 10 years ago. There was a thought that if you started dopamine replacement therapy too early, it would lose its efficacy. Turns out it lost its efficacy because of the progression of the disease. It had nothing to do with the drug itself becoming less effective. And so a lot of times people were never started on dopamine enhancing medications. There are other drugs that were used to try to help with the tremor and other things. Well-controlled trial compared that management to early treatment with dopamine replacement, and the quality of life in the people receiving dopamine replacement was vastly superior to quality of life in receiving the other approaches. So dopamine replacement therapy is really important, and we have 3 ways we do it. We give a dopamine precursor, that's levodopa carbidopa. We give things that are called dopaminergic drugs. They attach to the neuron receptors to which dopamine attaches. They don't increase dopamine levels, but they act like dopamine and work that way. And then the last way is drugs that slow the breakdown of dopamine. Because what goes on is dopamine has a certain lifespan in the nervous system. It's secreted, it will last unknown period of time, but it gradually deteriorates. And so there are the drugs that combat the enzymes that break down dopamine to allow your own personal dopamine, and if you're receiving dopamine replacement, to have that work longer. So number 1, the standard therapy is levodopa. And when I was in my training, I hate to think how long ago that was, I participated in the first trial of dopamine therapy, and it failed because dopamine alone, when given orally, makes people sick as a dog. So they couldn't tolerate it. Some brilliant chemist came up with the fact, let's add carbidopa to it, which seemed to moderate the nausea effects of dopamine and also help with the absorption of dopamine from L-dopa absorption from the intestinal tract. So as a result of that, levodopa carbidopa came on the market, and for the past 40 years, now 60 years, has been the hallmark of our therapy. like all drugs, levodopa, carbidopa have side effects. And I have a list of them there. I don't need to go over them all, but the most important thing is I have my little chart here. This is for people interested in pharmacodynamics. This is what happens when you take a pill of standard levodopa carbidopa. It gets absorbed, reaches a peak at about an hour, and then gradually diminishes over time. And this would be the level below which it has no symptomatic improvement. As the disease progresses and you have less and less dopamine on board, this bottom line of when the drug falls below a level you're not getting any effect goes up, and this ends up with this tiny little window up here that we call the therapeutic window, when your levodopa carbidopa is going to relieve your symptoms. Which is why, as the disease progresses, it becomes more difficult to adjust the dose, because we don't want to have people spending all their time up in here when they're having all the side effects of medication. So that's where you work with your movement disorder specialist to work on adjusting how your levodopa carbidopa is being administered. Whether it's by long-acting pills, whether it's by a subdermal infusion under the skin, there are whole varieties of ways to do it. So that's pharmacodynamics 101. The important thing is that levodopa carbidopa is bound by protein in the intestinal tract, so it doesn't get absorbed very well. So that's why you're told by your pharmacist or by your movement disorder specialist, be sure to take your levodopa carbidopa on an empty stomach or 2 hours after eating. Now, the 2 hours after eating is okay early in the disease, but as the disease progresses, the neurons that work in the intestinal tract get damaged as well. And all of a sudden the stomach isn't empty within 2 hours. So now you still have food in your stomach at 2 hours, and we still recommend 2 hours, but you're probably going to be getting less effect of the medication. The other little trick is that how things get through the stomach. The stomach has two curvatures to it. What's called the lesser curvature, which is the upper part, and very short, the greater curvature, which is how we hold all our food in the stomach. If you take this is used fast-acting levodopa carbidopa, not your sustained release. If you take your levodopa carbidopa standing, leaning a little bit to the right, and drink it with orange juice, because there appears to be something, at least in some people with Parkinson's, about vitamin C that speeds the absorption of levodopa carbidopa. So if you're standing, lean a little bit to the right and glug it down with a glass of orange juice, you will get faster effect from the medication. And in my reading of the literature, I don't see this listed very often.
Does that also mean it will still last for you?
It'll still last the right time, right? Because that's when it gets into the bloodstream. But yeah. The other thing is that if you have if you have the standard regular acting crushing, that pill will make it absorb faster as well. So crushing it, standing, and drinking with orange juice. For the sustained action, for the sustained release, you don't want to crush it, but for the short acting, you want to.
And that also causes gastrological problems.
Which does?
If you crush it or cut it in half, you get acid reflux.
Finding out what that is. I haven't come across that. I'll research it.
Okay, thank you.
Back. So when you're taking your levodopa carbidopa, you're adjusting the dose to how your symptoms are and how you are doing with any side effects of that. And so that's where you hear this lecture from us over and over and over again, is you should keep records, keep a journal once a week, twice a week, of when you take your medications, when you eat, what symptoms you're having and their timing in relationship to when you take your medications. Because if an hour after you take your medicine, all of a sudden you get a symptom, I don't care whether it's on the list or not, that's probably from too high blood levels of levodopa carbidopa. I had a patient who I prescribed a medication, commonly used medication, developed side effect, or at least developed symptoms shortly after taking it, and every time he took it, that's what he had. Nowhere in the literature did it mention this whatsoever. I had him stop the medication and the symptoms all went away. So just because it's not in the literature and not on the warnings doesn't mean it can't happen. So that's why I encourage people to periodically look at when they take their medications, and that's all medications, to try to see what interactions there might be, what side effects you might be having from it, and what effects you might be having. You know, if an hour after you take your levodopa carbidopa, all of a sudden you can brush your teeth, which you couldn't do before, that then says, hey, those muscles are working better. As I mentioned, the common forms are the standard short-acting form, and then there are a couple of long-acting forms. Levodopa carbidopa has a generic sustained action form. There is also a brand name called Rytary, which has actually been tested against the other form, the other combination of long-acting, short-acting, and it does seem to give a more sustained blood level. In Parkinson's, we talk about on time and off time. On time is when the drug seems to be working okay, your movements are pretty good. Off time is when all of a sudden, oh my God, it's as if I've never taken this medication. Speech gets softer, tremor increases, whatever your symptoms of your Parkinson's are seem to get worse. So the Rytary has been shown definitely to reduce off time. There's a new one on the market, that's Crexont, just released. It was tested against the previous long-acting, short-acting combinations that Rytary was tested against and found to be superior to. They haven't tested Crexont against Rytary, which is not unusual. Pharmaceutical companies don't like to test their drug against the most effective form because then all of a sudden they may not get it approved. So if you're being prescribed a long-acting form, it's a sustained release form, and it's Crexont, I would sort of maybe say to your neurologist, could we get Rytary instead? There's also a new form called Gehivi. This is a breakable tablet. It's an immediate, rapid release tablet. You can break it into 4 strengths, 6.25 milligrams, 12.5 milligrams, 18 3/4 milligrams, and 25 milligrams. And the reason for this is if you are someone who is doing okay with your medication, but your off periods seem to be getting a little bit worse, you can add small amounts of the drug to your usual levodopa carbidopa to see if with slightly increasing it will be of a benefit. The problem with the levodopa carbidopa preparations for the most part is they come in 25 milligram and above, so you can't do mild, tiny changes. And that's really just to people who need to boost it mildly to try to relieve symptoms. Inbridja, that is our wonder drug. It's inhaled levodopa carbidopa. This is for people who are now in a severe off period and want to get the hell out of it. It's inhaled, it's absorbed through the lung, it gets into the brain within about 20 minutes. So it will give you fairly rapid relief of a severe off period. It's like an inhaler used for asthma, and it contains just levodopa because it doesn't require going through the gastrointestinal tract. Vyalev is now the new one. That was approved just over the summer. It's like an insulin pump. It uses a precursor of levodopa-carbidopa. It's phos-levodopa and phos-carbidopa. There's a needle that goes under the skin. There's a pump you carry around with it attached to you, not physically, but you carry it on a device. And it will pump the precursor into the tissues under the skin where it gets absorbed, it gets into the bloodstream, is converted into levodopa-carbidopa, and then gets into the brain. So this gives extremely good control, and you can adjust the speed at which it's infused, just like an insulin pump. Works very well for people with late-stage Parkinson's disease.
So there was another one like that just released in February.
Right.
Acto or something?
I'll be mentioning that.
Did it mention that? I didn't hear.
I will be.
Oh, okay.
I'll be mentioning it because I'll mention it now. Apomorphine is the name of the drug. Apomorphine is a drug that acts like levodopa. The problem is it causes intense nausea. And as a result of that, you have to be on an antiemetic, you have to be on an anti-nausea drug to be using it. And there are a variety of forms. It actually comes as a little thing, a membrane you can put under your tongue that gets it absorbed rapidly to relieve off periods. There's a long-acting form, there's a short-acting form, just like levodopa-carbidopa. Now we have the infusion form. The problem is I'm always hesitant to prescribe a medicine that has to have another medicine along with it. We're already on enough medicines. And, the side effects, there is the best anti-nausea drug that we have on the market, you can't give to someone who's taking Parkinson's medications. So you have to take some of the older ones, which also have a huge array of side effects. So that's why I ignored it. Because we have other things that work just as well without
So
requirement.
Violet is another infusion thing, but it's better than the new.
Yeah, that's right. That's right. Yeah, because it's using a different drug. Duopa, that's the same thing as with the apomorphine. This uses levodopa-carbidopa, but you have to have a gastrostomy tube. You have a tube put through the wall, your abdominal wall, into your stomach, which is then passed down into your small intestine, and it's pumped in just as the levodopa-carbidopa under the skin will be. But again, when we have people in really advanced stage of disease in the intestinal tract, it's working very well. Because it has this invasive procedure, I don't recommend it. So that's the levodopa-carbidopa story. Questions? No?
So, you have your medication spread out for the 24-hour period. Would it be beneficial to have it so that it's spread out only during your awake hours rather than through your sleeping hours?
Well, the problem is, how would you then get out of bed in the morning? That's the hard part. Yes, but you would now be in an intense off period. And if it's 4 in the morning, all of a sudden you had to get up and relieve yourself.
Okay.
Which is why generally we have people that generally your movement disorder person will have you taking a long-acting form at bedtime. So it's still in the bloodstream and in the nervous system, when you get up.
Okay.
I mean, if you space it out 8 hours apart,
Yeah,
go to bed at
right,
11, 10:30 or 11,
Yeah.
it's usually you're up by the time.
right, yeah. But even so, they'll often use a long-acting form of it. Dopamine agonists, they're medications that work like dopamine and they have the same side effects as dopamine. One of my favorite side effects of too much dopamine or of the dopamine agonists is a thing called compulsive behavior. That side effect is compulsive gambling, compulsive spending, compulsive eating, compulsive sex. I mean, it's very, very interesting. And once you get off the drug, or lower the strength of the drug, that all goes away. So it's nothing that stays with you. But that's one of the interesting side effects.
Might be
But-
fun.
Yeah,
Might be
it
fun.
might be fun depending on which one you get.
But, we have Del Lago just down the road, so I don't want to.
Right, that's the worst one to have. Yeah, and they work very well. They are frequently begun in people before we start levodopa carbidopa. It was a sort of tradition to use these also early in the disease. And they can be added to levodopa carbidopa later in the disease to get more benefit, to get better control of your Parkinson's. So they're not, instead of levodopa carbidopa, they're frequently in combination with it. And it comes in several forms. It actually has one that's a skin patch you can put behind your ear or on your arm or such. So that gets absorbed over time. Amantadine that was a drug that was initially designed for people with Parkinson's, but it turned out to cure influenza. So it went out of favor for Parkinson's disease until it got used so much that influenza was now resistant to it. And now it's back being used in Parkinson's as well. And it has the big advantage is it seems to prevent the dyskinesias. In Parkinson's, when you're treating people with levodopa carbidopa or dopamine agonists, if you get too much, you develop these strange body movements, grimacing, moving around, called dyskinesias. The amantadine, and it comes in a long-acting form, Jocovri, is very effective at reducing the dyskinesias, and also gets an added benefit of having a dopamine-like effect to it. And there is yet another dopamine agonist, which isn't on the market yet, called tavapadon. It's not yet approved, but it seemed to work very well with few side effects, but it hasn't been vigorously compared with some of the other dopamine agonists. So I would say turn the page. Drugs that have been on the market for a long time, these things called MAOB inhibitors, that's monoamine oxidase B, used, again, back in the old days, used very early in the disease because they increased your dopamine levels. They seem to be very effective. They have few side effects, except for the fact they interact with certain foods that actually make you have side effects, and from certain medications. So as long as you're watching the warnings on what not to eat and what medicines not to take, they're very effective and very safe. They really don't have any hazardous side effects. And Virapax, which is a dopamine agonist, and Azilect, which is a MAO inhibitor, are now in a combination form. And again, it seems to be a very good additive to your levodopa carbidopa in either alone or late in the disease, and again, with very few in the way of side effects. Then there are a group of things called the COMT inhibitors. They interfere with an enzyme called, I'm going to block on it, carboxymethyltransferase. That they help improve the survival of levodopa carbidopa in the bloodstream and therefore can prolong the blood levels of it. They're available to be taken separately or in a combination with a combination long-acting, short-acting levodopa carbidopa. That is a drug called Stalevo, which is be very similar to the Rytary, except it has the addition of the medication to slow the destruction of levodopa carbidopa. And then there is the last one, which is works by a different mechanism, but has a similar effect to the Comtan of just slowing the destruction of levodopa carbidopa. I'll also mention first drugs that were ever used, the anticholinergics, these again have very strong list of side effects. They were used predominantly, they now would be used predominantly if you have tremor that hasn't responded to your levodopa carbidopa or deep brain stimulation. They seem to have a nice additive effect. Questions?
So what would drive the decision on when to start medication?
It's really how your symptoms are. I mean, the studies that have been done say you get such good symptom relief that if you're having disturbing symptoms, and I will say let's use the phrase disturbing, because that's what drives most of us to do anything anyway. If you're having disturbing symptoms from your Parkinson's, then that would be the time to take the medication. Starting it early is not going to cause any less effectiveness down the line. It's not going to change the progression of the disease. So starting a medication is purely a decision of how much, whatever their symptoms are, how badly you are being bothered. But by not starting the drug, you're not doing any harm.
You have the potential side effects.
No, except the side effects are trivial if you're watching the doses. But as far as hazardous side effects, and as far as things like kidney failure and heart failure, nasty things that can happen, they don't have, levodopa carbidopa doesn't have those side effects. Yeah, basically symptomatic. And the way to test it out is, you know, if you have a symptom, you say, gee, I don't necessarily to test it, but I don't like it, is to start a low dose and see what happens. Which is why, again, I recommend the trimming sort of thing, because if you have a dramatic effect, you'll say, gee, isn't this great? If 2 weeks later you suddenly start saying, gee, I'm not having this anymore, then you might be able to say, maybe this drug is working. Yeah, but there is no medical reason not to start drugs or to start other than sense of well-being.
Except you're saying that the gait balance predominant.
It's going to be is less likely to respond. However, as I mentioned, our founder, you still have a possibility. So, you know, it's a matter of if the symptoms are bothersome, trying.
With the gait imbalance and, you know, in our experience, in Craig's personal experience and my observational experience, over the last 4 years, maybe even longer, we're back to the same thing again, which is doing different things with carbidopa.
Right.
And I'm wondering why, it's been a couple of different neurologists, not the same,
right,
and not in the same community. Why would Craig not be tried on something else?
Basically, the problem is the only things that work are those things that relate to dopamine. I mean, the only things that help, and I'm talking about the motor symptoms, the only things that are of any benefit are dopamine related, whether things that slow the destruction of dopamine, act like dopamine against the dopamine receptor in the neuron, or actually produce dopamine in the brain. So, I mean, why they keep on trying it over and over again without success, it's probably from the dread of not having anything else to offer.
Because the other types of medications that you spoke of are not as effective. You talked about a number of different medications.
Yeah, they're all effective.
Okay.
I mean, they all work on the dopamine system. Yeah, they all have the, and you could try, I mean, you might go from levodopa carbidopa to a dopamine agonist, from the X-like dopamine, to see if there is any difference. I mean, the logic is probably not, but I mean, there certainly would be a rationale to go from levodopa carbidopa to dopamine agonist of some sort. And then not all dopamine agonists work by exactly the same mechanism. You might switch from one dopamine agonist to another and see if that has any effect. Everyone heard the question?
Not that I want to get personal, but the thing that's bothering me about this is I don't have the tremor, but I have 4 from column A and 4 from column B of the other symptoms.
Right, yeah.
What do I do?
I would obviously try levodopa-carbidopa.
Oh, that's what I do.
Yeah, or a dopamine agonist. Yeah.
I am trying, I have a.
Yeah, yeah.
I
I mean,
have,
as I say, the thinking changed about 10, well, actually less than 10 years ago about holding off on levodopa-carbidopa. So I would start levodopa-carbidopa and see how it does. And that's where, again, keeping track of how the symptoms are, whether it's working or not.
See, some of them are so subtle that,
Yeah.
obviously, tremor started up, and I know I need to.
Right.
Some more.
Right.
But these other things, it's not quite so.
Well, it's by having the tremor, you are now in tremor predominant.
Okay.
Because all the other things go along with Parkinson's at some point or other.
Okay.
It's when it starts with the shuffling gait and the soft speech and such, that's when, without any tremor whatsoever. But then that's when, yeah. So I'm going into questions now. And there were a lot of very, very good ones. One of which is late in life diabetes the result of Parkinson's disease? The answer is no. However, about 80% of people with Parkinson's will have diabetes, either as a precursor or later on in the disease. It appears to be related to what's going on in the microbiome, because if you feed gut bacteria some artificial sweeteners, it increases your risk of developing adult onset diabetes. So it may very well be that you have a disease that Parkinson's appears to be also related to the microbiome. So you have a microbiomal disease. Microbiome is the trillions of organisms that live in your intestinal tract that have all sorts of endocrine and metabolic effects on your body. So the answer is there's a risk of people with Parkinson's are high risk to have diabetes. And very reasonable to get tested for it. Two studies going on right now to see if Mediterranean style diets will help the microbiome and therefore help the development of Parkinson's disease or its progression. So far they have the microbiome doing quite well, but it's too early to tell whether it's having an effect on Parkinson's patients. Explain peripheral neuropathy. Peripheral neuropathy is a situation where it's the nerves to your extremities. Actually, it's any nerve to the surface of your skin or any sensory nerve anywhere. And that usually occurs late in Parkinson's disease. It can present as pain, it can be numbness and tingling, it can be muscle weakness, it can be weakness from the damage to the nerve itself. Or greater sensitivity. Could be you feel burning in your fingers. So yes, there is an increased risk of peripheral neuropathy in Parkinson's. Is sleep apnea common in Parkinson's? Sleep apnea is a condition where in the middle of the night when you're sleeping, all of a sudden you're coughing and choking or suddenly stop breathing. This creates a long-term risk of chronic lung disease, problem with not getting rid of carbon dioxide overnight. And yes, indeed, it does. Both the tremor predominant and the gait balance predominant are associated with sleep apnea. So if you're finding yourself getting uncomfortable or sleep that doesn't seem to be rewarding, you're waking up as tired as you were when you went to sleep, or your bed partner is saying not only is the person beating up on me, which is part of the condition with sleeping in Parkinson's disease, is also stopping to breathe periodically or snoring like fury. Good idea to get a sleep study done. There is so-called obstructive sleep apnea, and that's where the soft palate sort of collapses back into the airway. And then there is central sleep apnea, which has to do with the sleep centers in the brain and so on. One was, how does a caregiver insist on getting the care partner, the person with Parkinson's, to stop driving? Very, very difficult to do. I can tell you from the physician point of view, I always hated to be asked to tell the patient not to drive because they wouldn't listen to me the same way they listen to the spouse. We did have a driver rehabilitation expert speak to us previously. Unfortunately, driver rehabilitation people are scarcer than hen's teeth, and getting an appointment with them, my understanding is it's very, very tedious and tenuous, but anyone who's interested, I can get you the phone number of the speech or the driver rehab person. Similar, there was a question, why does my beloved one insist that she doesn't need all the Parkinson's medications and self-medicates? I would contact your partner's physician, or the person prescribing the medications, to try to talk to the person. I find trying to get people away from things that they get into is virtually impossible. And the other one was, how do you handle denial in the person with Parkinson's? I used to think it was a purely male disease. I always said the longest gene on the Y chromosome was denial. Very difficult. Again, I would mention to the person's physician that they're denying what they have and try to have a talk with them. Someone was asking about urinary infections, masking some other disorder. Actually, it's in people with advanced neuromuscular disease. Urinary tract infections are very common, but they don't present with the symptoms that all the rest of us have. They don't have urgency, frequency, burning, and that sort of thing. It's usually change in behavior. They can have, it's probably the most common cause of delirium in the people in the hospital and in the nursing home. Suddenly become very confused and agitated and such, and you check a urinalysis and they have the urinary tract infection. So yes, with neurologic disorders, we don't urinate as well as possible. We're at risk for infections, and they can cause, you will have abrupt changes in the person's neurologic symptoms. So if there's a care partner, a person with Parkinson's suddenly has a really acute change in what's going on, think possible urinary tract infection. A question about conscious sedation for colonoscopy. That appears to be safe in people with Parkinson's, but I always say when you go for any procedure, you need to tell the person who's going to be sedating you about your Parkinson's and like what medications you're on. The only caveat in sedation for colonoscopy is if you are fully sedated, if you're giving something that really totally knocks you out, you're at increased risk of having perforation of the colon during the colonoscopy. Our marvelous drug Versed, called midazolam is the generic name. It's a marvelous drug. It's like Valium, but it wipes out your memory. So you are actually awake, but you can't remember anything about it, and that keeps the operator from damaging your colon. If the person starts beginning to grimace, you know, oops, time to back off, take some bends out of things and go ahead. So my favorite story was a wife of a patient I'd done a colonoscopy on. About a week after he had it done, she said, I took him out for lunch afterwards. And as we were walking out of the restaurant, he turned to me and said, let's go out for lunch. He had no recollection. And that's also when you go for one of those, you are advised not to make any promises, sign any contracts, and make any debts. So, question of infusions before CT scans. Is this anesthesia? No, it's a dye that's used to help image. And it's the same thing with radionuclide studies, where you're given a radioactive substance, lie under a scanner, and it shows where that radioactive substance is in the brain. They're perfectly safe. Again, just be sure your radiologist knows that you have Parkinson's. Let's see. Person said his body leans to the left in Parkinson's disease. Wondered why, and that's because Parkinson's usually presents itself unilaterally, usually presents on one side. So what you have now is muscle weakness on one side, muscle strength on the other side. And so, of course, you can bend to the side. Physical therapy should help, activity should help. And again, that would be a situation where a trial of a dopamine agonist or levodopa-carbidopa would be in order. Why the flat face? And again, is the muscle weakness as a result of the neuromuscular disorder of Parkinson's? And that would again benefit from treating the disease, but also the physical therapy, working on your smile. And the final one, another question was, why is the person losing strength and stamina during activity? And that's because you don't have enough levodopa-carbidopa on board. You should have enough on board so when you now need it more with the physical activity, it's there to do it. So often taking a small dose of short-acting before, like half an hour before you, or to an hour before you engage in that physical activity. And then there were a number of questions about dementia, but before that I want to go on to the surgical management. It's still on the forum. Deep brain stimulation works very well. This is putting an electrode in the part of the brain that has to do with motor function. Very effective. In good hands, it's quite safe. Obviously, like any surgical procedure, there are risks to it, and so you want a good discussion with your neurologist. The tendency is to be doing it earlier and earlier. We have some members of our group who have had deep brain stimulation 15 years ago, who are still going strong. Neuroablative therapy, this is where they use focused ultrasound, actually high-pitched sounds that go into the brain and burn the brain. This is used for controlling tremor that's not controlled otherwise. Problem is you now have damage to the brain. And if you look at Michael Fox was in the pre-deep brain stimulation era. They went in and ablated the section of his brain that was causing his tremor. Of course, he was left with the dyskinesias as a result of that. It also has been used to interrupt the blood-brain barrier. The tissues around the brain are very good at keeping substances that are in the bloodstream out of the brain. And so by using focused ultrasound, you can ablate part of the blood-brain barrier, and that allows medications that normally wouldn't get into the brain that could get into it. And there are a number of experimental studies that have been using that. And then the final one, which wasn't on my list, was I came across, someone asked me about phototherapy. Well, it turns out phototherapy works. This is using a light box. You can get them anywhere because they're used for people with difficulty with sleeping. It's bright white or shortwave blue or green light. Studies look best if you do 30 minutes of that in the morning. It has been shown to significantly improve motor function, significantly improve depression, and significantly improve sleep. There is something about bright light that stimulates the production of dopamine. And very interestingly, so it looked to be effective. Light boxes are cheap, certainly worth a try. I would not use it later in the day because it interferes with the production of melatonin, which is our natural sleep drug that is produced as the light begins to fade. So morning dose is the best time to eat it. Last questions I had were about dementias. I'm wondering, we know that part of Parkinson's can be this thing called Lewy body dementia. Lewy bodies are, the reason they're called Lewy bodies, there was a French pathologist in the early 1900s, Dr. Lewy, who found them in people with Parkinson's disease. It's the misfolded alpha-synuclein in the neurons. So that's the dementia that can develop. But Parkinson's has a cognitive problem right from the get-go. People with Parkinson's have a tendency to lose their what's called executive function, which is being able to put things in order and stratify what they do during the day, take care of things. And they also often lose their sense of where they are in space. So there is a spatial disorder that seems to go hand in hand with Parkinson's. Lewy body dementia obviously has that. And early on in it, there is no problem with the motor function or with memory. Only as the disease goes on over time do they begin to develop what you would consider classical dementia. They also have visual hallucinations with this and staring into space and things of that sort. They can get very agitated, and memory loss, as I mentioned, is late in the disease. Alzheimer's, on the other hand, that's felt to be due to a tau protein called tau protein building up in the brain. Although it's interesting, there have been now a number of people found to have severe amounts of tau protein in their brains at the time of autopsy who have no symptoms of Alzheimer's whatsoever. So, but we're currently blaming tau protein. It starts with memory loss. So trouble with calculating, losing things, getting lost, that is their typical Alzheimer's. There's also vascular dementia, and that's in people with long-standing cardiovascular disease. Blood vessels to the brain begin to get narrowed. Again, memory will get lost, but it's later in the disease. Usually starts out with apathy, and probably one of the most common one is a long, broad-based gait, sort of a staggering gait, but also will end up with a dementia phenomenon. And there is my favorite, which a friend of ours had, which is frontotemporal dementia. And that's one, again, which starts with behavioral changes. They get very impulsive, tell dirty jokes. I remember this one guy who we were with, we were on a bicycle trip, and we're driving along, and all of a sudden he decides to stop, and stops, and immediately urinates on the side of the road, still on his bicycle. And then we were in a restaurant, and we were talking, and the waitress hadn't come by yet, so we started ramming on the glass to get the waitress to come around. He later turned out to have frontotemporal dementia. They have trouble with language, spatial skills, etc. But memory stays intact, so this guy could remember everything that was done in his life, but certainly his behavior wasn't very good. So that's Parkinson's disease and everything else in a nutshell. Questions?
I just have a question on the frontotemporal dementia.
Yes.
What drugs would you use when you have Parkinson's, but you have that frontotemporal? Are there additional drugs on the market?
There are drugs for Alzheimer's. I don't know how effective they are. I haven't really researched other than having this friend who actually had a patient who had it started in his 40s. At that point, there were no drugs available. That's also ancient history.
Could you mention some of the drugs that might be used with orthostatic hypotension?
When I'm talking in, I think, October.
Oh, okay. No, that's
Or
good.
that's going to be the non-motor symptoms.
Right, I
of
realized
Parkinson's.
that, but I just wondered
yeah.
if maybe.
And that goes along with the neuropathy. I mean, that's basically an autonomic neuropathy, autonomic nerves, some sweating, gastrointestinal function, urinary function, normal contractility of blood vessels.
Another broad area, we'll be back.
But yes, there are drugs that are very effective. Check with your neurologist. The other thing is support stockings. I would put them on when he goes to bed at night, and be sure to have them on when you get up in the morning, because that will help reduce the likelihood of the blood pressure dropping when you get up. The other thing is sitting at the edge of the bed before you get out of the bed and pumping your feet. That also helps. I did have a patient who, and it was had a friend in the Air Force, and he actually got a G suit for himself. The sort of thing that's a pressure suit, you wear a total pressure suit, and that controls his orthostatic hypertension. Hell of a thing to get in and out of. Yeah.
For exercise for the day too.
Right. The cookies.
Is there any drug is effective in vision?
The answer is, if it's a matter of the ability of the neurons to respond to light, the answer is that's where levodopa carbidopa might help. If it's a matter of double vision, which is the muscle weakness, again, if that has had no improvement with levodopa carbidopa, generally what's used is prisms in your glasses. So to work on getting how the light strikes the eye lined up. So double vision, very common in Parkinson's, from the muscle dysfunction. And generally it's trying to treat the muscle dysfunction if that's not working. Prisms with it. And exercises, eye exercises have also been shown to help. You know, following things along and trying to go in with your finger and such.
Nitrous oxide, how is that helping our circulation? And humming?
It actually works as I'm pretty sure nitrous oxide works as a vasodilator. So it actually relaxes arteries. It's an arterial dilator. So, yeah. Humming, right.
Can help.
Can help. Well, that's excellent exercise, again, of the diaphragm and the vocal cords and the chest wall muscles. It's an singing too. Yeah.
Won't cost anything.
That's right. Only in the shower, though. Otherwise, it might cost friendships. Good.
One more thing, we have a generous donation of quad cane. So if anybody would like a quad cane, get it today. Otherwise, it goes back to my house. Goes to my house and goes on the bulletin board. So it's right here. It's beautiful. Thank you for the donation. It's a nice one. So I'll leave it right up there. That's it.
Very good. So the cookies up here, and then we'll adjourn to the third floor or stay here.